Good afternoon. Hello, everybody. Thanks for logging in. We're just going to wait a few minutes for people to connect in. Just while we're waiting, if you could let me know in the chat if you've had any experience in patient safety. So either doing patient safety work to improve the safety of patients, or if you experienced any sort of particular issues that was a patient safety problem.
James, it's Shannon here. Can you
Hi.
hear me? Hi, sorry,
Yeah.
I just can't find where the chat thing is on my Teams, and like I don't have particularly any experience, but I just wanted to let you know that it's not me being
Okay.
radio silence. I just can't find the chat function
Okay.
on
Maybe you
it.
could just tell me now you're unmuted.
Um, I'm like in terms of patient safety. Well,
Yeah, if you had any experience.
I guess my experience is probably more in an individual case, like when there is safety issues, and then as team reflection, like I'm a clinician, not a management or leadership as such.
Yeah.
So it would be on a case by case basis, but we're always using those reflections to learn from to
Yeah.
improve
Yeah.
patient safety. But in terms of monitoring that as my day-to-day practice, like I guess it's always in the background, isn't it? That's what
Yeah.
we're involved in, is delivering care but at minimum risk to our clients.
Yeah. Yeah.
Mm.
Thank you. Okay, well, I'm sorry, chat boxes somehow disappeared. But we'll get into it now. So yeah, this lecture is the first in the sort of the series of patient safety. In terms of the overall course, there's two main areas of quality improvement. One, which we've been going through previously, is quality improvement. So that's, identifying areas for improvement, thinking about how to measure that, and then thinking about improvements to put in. This is a patient safety aspect, and it's just thinking about the different sort of aspects of how errors and harm can occur and how we can prevent them. And so when it comes to then preventing them, that's when you would use a quality improvement approach, usually to improve the safety for a whole system rather than just one patient at a time. But it is a very big topic. So we're going to talk about the Swiss cheese model, which is um, pretty old model now, but still works most of the time in kind of helping us understand safety issues. We're going to talk about active failures and latent errors. We're going to talk about the different types of unsafe acts, and we're going to talk a little bit on, how what approach we use in patient safety is on reducing errors or reducing harm. So the first thing we're going to talk about is what is harm, and then we're going to talk about the Swiss cheese model, and then we're going to understand unsafe acts. So what is harm? This is one definition that was around for a while. It's probably not up to date anymore. It says the unintended physical harm is the unintended physical injury resulting from or contributed to by medical care that requires additional monitoring, treatment, or hospitalization, or that results in death. So it's a fairly narrow definition. It's yeah, it's got some problems, and it leaves out quite a few things. So in the definition, it says that harm is unintended, but harm can occur, or hopefully not intended harm, because that would be a criminal act. But what about harm that occurs as a necessary evil? So it's something that is a recognized complication of a treatment, for example. The definition also talks about medical care causing the harm, but what about harm that's caused by a system? So where we don't provide care that we should, like we miss diagnoses, or patients' care is delayed to the point where they've come to harm. That is a harm that's caused by a system, but not actually a harm caused by giving medical care as such. It also talks about harm being physical, but we know that actually probably, what is worse than physical harm is the psychological harm, because physical harm you can, recover from. Eventually, hopefully the physical pain would go away. The physical condition might be rectified. But the problem with psychological harm is that it's something that you can relive over and over again, especially if it was very traumatic. And certainly financial harm is something that can take quite a while to recover from. And then it also talks about the harm leading to additional care. But what if the harm didn't? Does that mean it's any less important? Probably not. There's a lot of patients who just accept it and move on rather than seeking out additional care, or maybe there isn't available resources. Say they only suffered psychological harm. Well, our psychological services are so threadbare at the moment that even if they wanted additional care, they might not receive it. So yeah, it's so we've redefined harm more recently to try and just think of it more broadly. Uh, and to think of the fact that unpreventable events are actually not unpreventable. That so even consequences of treatment which are inevitable today may not be inevitable in the future. For example, central line bloodstream associated infections. Putting a central line. At one time, we accepted that there was a infection rate that could happen, but now we've found out that you can almost reduce that down to zero if the right processes are in place, and it's about getting the system to follow those processes every time. So by using a broader definition, it helps us think of all the ways in which we can prevent harm happening to the patients. So how does harm occur? Um, well, harm itself can occur on its own where nothing wrong has happened. There's been no errors, and that might be like a side effect of a drug, for example. We know that the drug may cause some headaches, um, but we give it to the patient because it's going to treat them, and indeed it makes them feel better with regards to their diagnosis, but the side effect is a headache. That would be harm without error. And then we've got on the other side, we've got errors that don't cause harm, or what we call near misses. And those are the opportunities to prevent the middle section, which is error leading to harm. And there are two types of errors, really. One is latent conditions, and these are things that are inherent in the system or the environment, um, or the treatment that is provided. They're often in the background. We often accept them. We often say this is just the way it is. And it's only when you have a new piece of equipment come in or a new system that come in that you suddenly realize, well, we could have done things differently. So those are latent conditions, and those are the sort of the underlying unsafe environment, so to speak. Then you got active failures, which are things that happen that have a direct effect to cause harm. So like somebody pushing the wrong button or ignoring a warning. And whilst that frontline effect has a direct cause, we always think about the root causes. So what what environmental things, what systematic things eventually led to that wrong button being pushed or people ignoring that warning. And that's the whole basis of root cause analysis, which we won't go into today, but it helps you understand that we never just focus on the direct failure that led to the harm. We always want to think about the whole environment in which that happened. And that leads you on to the Swiss cheese model. So we always think about failures not as the result of just that last layer of defense of somebody doing something wrong or something wrong happening, but all the things before it, all the checks and balances that also failed to allow that error to act, those errors to actually result in harm. So in a Swiss cheese model, if not all the holes line up, then what you have there is a series of errors which do not lead to harm because one line of defense has worked. And those are the opportunities to say, okay, how can we fill in the holes in the other areas, the gaps that it did get through? Of course, if the holes all line up, then the patient falls through. Um, so we're really focusing on at the moment on errors here. So what are errors? Well, there's a lot of different types of errors really based on whether it's intended or unintended, um, and whether it was to do with how knowledge was applied or skill was applied. So at the very top, you've got a broad sort of definition of unsafe acts. That's things that have happened that could lead to a potential hazard. And then you could divide those into two main categories. One would be violations, which is deliberate deviation from what is perceived to be the safe way to do things. And deliberate deviation might be for good reason, or it might be for a selfish reason, or a reason that is not in the patient's best interests. Then on the other side, you've got errors. So that's where you fail to carry out a planned action as intended, or you did the wrong thing. So that then leads you to divide up these errors into two main things. So the action did not go as intended. So you chose to do the right thing, but the execution was wrong. either due to a slip or a lapse, so mental error or execution. And then on the other side, the action goes as you wanted it to, but it was wrong. So you chose the wrong drug, or you did the wrong operation, or you applied the wrong protocol. And those are mistakes. So that's a mistake in decision or planning, or a defect in knowledge, for example. So then mistakes we can divide up into two things. One is where it stems from a lack of knowledge, or one is where we have the right knowledge, but it's been applied incorrectly. So if you are able to categorize errors, then that helps you think about the remedy, the solution a bit better. So if it's a knowledge-based thing, then obviously the thing that's going to make it better is improving knowledge. If it's a rule-based mistake, then the way to improve that is maybe with decision tools, or taking the decision making out of your hands altogether, for example. So here is a little mental exercise trying to work out what type of error each of these is. So first one, you forget to tell your patient to schedule a follow-up appointment. The second one is you try to give your patient a pamphlet on eating healthy, but grab one on sleep hygiene. You don't wash your hands because you're distracted. You don't wash your hands because you don't feel you have time, and you misdiagnose your patient's pain. So the first one is a lapse, because it's about forgetting. You know what to do, you know the right thing to do, it is the right thing to do, but you just forgot. The second one is a slip. So you're intending to do the right thing, but the execution was an error. You just grabbed the wrong thing. It was a skill thing. The third one, you don't wash your hands because you're distracted. So you're intending to do the right thing, but you ended up not doing it. You forgot. You just didn't do it. Lapse. You don't wash your hands because you don't feel you have the time. So you know you have to do it, but you choose not to do it. That's a violation. And then last one, you misdiagnose your patient's pain. That's a mistake. And it could either be a knowledge-based mistake or a rule-based mistake. So a knowledge-based mistake might be what a junior doctor does because they don't have enough knowledge about that patient's condition to make the right diagnosis. Or a rule-based mistake might be that, it might be something that a more senior clinician makes, that they have the right knowledge, but they pick up on the cues in the wrong way. Or they are biased by the previous patient that they saw having the same condition, and applied the wrong logic. Okay, so when we are trying to get rid of errors in our system, we're trying to focus on rather than just focusing on the individual at the front, we're trying to focus on the environment that wraps around to try and prevent that error ever being possible. So that would be the ultimate safe environment where doing the wrong thing is impossible. So, for example, minimizing conditions that lend themselves to violations, if there is, I don't know, for the hand washing example, we could have a system where when you exit a bed space, the door will only unlock once the camera has seen you wash your hands for 20 seconds. That would definitely prevent hand washing not being done. Putting mechanisms in place to mitigate the effects of unsafe acts that may inevitably occur. So, I don't know, say it's inevitable that the floor is a little bit wet when we mop it. There's probably not much you can get around that. I suppose you could dry it immediately, to prevent that, but maybe we need the drying effect to make it more sterile. So there is a period where it's unsafe. So the mechanism in place, we could, I don't know, extreme example, we could evacuate everybody from that room until the floor is dry. Yeah, that would definitely work. It's probably not feasible, but you can see how if you think big and wildly enough, you can actually mitigate most sort of risks. That leads us on to blame versus accountability, which is always the real problem in patient safety work, because it's probably inherent in human nature to look for blame and accountability when things go wrong, and it's probably the one thing that makes patient safety work so difficult. Because you're dealing with human beings who want to protect their reputation. And so when it comes to trying to figure out what has gone wrong, getting to the bottom of it all, you encounter barriers such as people trying to protect their reputation. So it's important to, first of all, as a practitioner who's doing patient safety work, to really be clear on, where you have to think about blame and accountability, and where you can think more in general terms of systems. And if you look at things through that lens, you'll start to realize that there's actually a lot less that you can actually blame an individual for, because you're taking a root cause analysis look at it. You're looking at all those layers of cheese and realizing that blaming an individual is really a very small part of the whole problem. And if you approach people and you preface your approach with, I really have a better understanding that this is not down to one individual, and we're not looking to blame, you're likely to get a bit more openness. However, you can't get around it entirely. There are situations when you will uncover people who have done the wrong thing and maybe need disciplining as a result. And that is also part of patient safety work, where you found that there are unsafe violations due to staff that needs also to be tackled head on. So it's difficult. This is a decision tree which helps you probably realize that it's actually a spectrum. It's not were you to blame or not. It's much more of a spectrum. So on the left hand side here, we got sabotage, malevolent damage, suicide, criminal acts, really, basically. So where we knew that something was unsafe and we did it for selfish reasons, for example. And then on the very other side of the thing, that is that slice of the Venn diagram right at the beginning, where error has occurred, but there is absolutely no blame to be apportioned to anybody. It's an error that occurred. And then there's everything else in between. So you might have an issue where a member of staff is misusing substance. Is that whilst they have a medical condition, are they on maybe opiate analgesia for a good reason, or are they just addicted to drugs without any medical condition? Are they violating safe operating procedures because they are just don't want to do it, or is it because they don't quite understand what they should be doing? Is it something that they're trying to do the safe act, but actually the system itself prevents them from doing something safe, So there's everything in between, and that kind of helps you understand that culpability is a big sliding scale. So overall, the patient safety field has really broadened from looking at individual harm, individual errors, and how that affects patients and harming them in a physical way, to a much more broader sense of um, how do we prevent harm in its broadest sense to our patients, and how do we also look at episodes and events that have not led to harm but are good warning signs that eventually something will happen, good warning signs that the system itself is a bit unsafe and we need to find those unsafe things and then create an environment where those unsafe acts and episodes are much less likely to occur. Okay, so that's it basically on talking about it, and I want to show you this example. So I'm just going to make sure that you can hear the hear it. So let me just make sure. Go to settings. Okay. Right, you should be able to hear it. I'm going to play it now. But if you can't hear it, wave your hands at me or something. Oh, you can't hear it. Okay, just a minute, sorry. Right. Sorry about that. I used to be able to do this. I wonder how it can work. Ah, I found it. It was on a different toolbar. Teams, you put things in all different places. Right.
Different hazard, one we rarely. We go outside of healthcare to see our system in a new way and get fresh ideas for improvement. Today we're going to learn about a safety system to handle a totally different hazard, one we rarely face in healthcare. We're going to look at dangerous snakes.
Hi, I'm Kathy Duncan, and today we're going outside of healthcare to the Central Florida Zoo.
The Central Florida Zoo has a lot to teach us about safety. Specifically, we're going to learn 3 valuable lessons about reliability. In order to create reliable systems, we need to prevent failure, identify failures and mitigate their effects, and learn from failure to better design our systems. How does the zoo apply those concepts when handling venomous snakes?
My name is Michelle Hoffman. I'm a reptile keeper at the Central Florida Zoo. I've been here for 4 years, and I work with one of the largest collections of venomous reptiles in the Southeast within AZA Zoos.
Michelle took us behind the scenes to show us how they stay safe when handling snakes, to clean their enclosures and to move them.
The red and the green cage cards actually will tell us at a quick glance if the snake in the enclosure is venomous or non-venomous. So the red obviously is the venomous, the green is the non-venomous, red stop, green go.
And what's this number 1 up there?
The numbers above the enclosures actually tell the keepers how many animals are in the enclosure. So for example, there's only 1 Aruba Island rattlesnake in here, and there are 3 pythons in that enclosure. So we know if we open the door and we only see 2 animals, there might be one hiding somewhere, to keep your eyes open and actually find all of those animals before you reach in or before you do any work in the enclosure.
All this helps prevent snake bites. But what if a failure does occur? When keepers handle snakes, they work in pairs so that if something goes wrong, there's a trained person there to help them.
We're expected to work really closely with our coworkers and our managers. We have a very open relationship when it comes to trust and being able to speak up.
They also use a belt clip with key information about the snake, such as the antivenom.
So that way, if something goes wrong, somebody can come in from the outside, know exactly how to handle the situation and which antivenom to bring with you to the hospital.
This helps to reduce harm if a failure does occur. The next principle of reliability is that you may redesign your systems based on what you've learned from failures.
It's been over 20 years since we've had a venomous snake bite here at the Central Florida Zoo, and one of the reasons for that great track record is because we were always adapting and adjusting and learning how to improve our systems to prevent any failures in the future.
For example, they used to use a lanyard instead of the belt clip with all the snake information.
We actually switched it to the belt clip in order for it to be completely out of our way and not in any sort of position where it could get attached on anything or a snake's tail could get hooked around it or anything like that.
They also modified their trash barrel to have a plexiglass window on the top so that they could see where the snake is.
One of the main ways that we do learn is from other people, other facilities, other reptile professionals. So we are expected to have close relationships with those colleagues. If we have a system that maybe went a little bit wrong or that maybe wasn't working out the best, we can go to them and ask for advice without feeling like we're inferior or something like that.
Every time I visit the zoo, I see opportunities to standardize, mitigate failure, and even redesign the work. But they've taken opportunities to really look at how they can keep not only their keepers safe, but they can keep their animals safe. So as you go about your daily work and daily life, look at other opportunities to really see how you might can bring things back to healthcare.
There we go. So we're just going to have a quick sort of discussion about this. I always find that learning from other industries is really a great way to sort of get some good ideas, get a different perspective on what we have in healthcare. It's just a really good way to learn. So if you ever have an opportunity to go visit another different industry organization with a quality improvement lens on, then definitely jump at the chance. This video lists 3 principles of reliable design. Have you seen these same principles applied elsewhere? So obviously so those principles were trying to make the environment as safe as possible, learning from failures, and mitigating the effects of failures. So have you got any examples of that at all that it happens in your area? So I'll give you an example of what happens in my area. In surgery, we have monthly meetings called M&M meetings, mortality and morbidity meetings. And this is where all the doctors usually get together in a room and discuss patients who suffered complications and deaths. And the purpose of the discussion is to identify any areas where we could have done something different, or if there were any systematic problems that we need to address. The things that make an M&M meeting work is that there is a good culture of people knowing that whatever they say in the room is not going to be shared outside the room at all. So it's confidential. It means that people can protect their reputations, and share and be honest about what happened. So you'll often get in that room quite senior people saying, yeah, maybe I should have considered this before we did this, or I didn't quite appreciate this, and that led us to doing the wrong thing. And that is very good from a personal, professional point of view, but it also signals to the department that we're all about learning and improving for the benefit of our patients. So that's an example of learning from failure, and it's really good because quite a lot of things that happen in healthcare are rare events. You know, just like the zoo, for example, where they haven't had a snake bite in 20 years. They're not waiting for the next snake bite to then change things. That is the sort of the firefighting approach, which is quite common in healthcare. And it also used to be common in the airline industry, for example. You would wait for a plane to crash before you would investigate it and learn from it. But now, in that zoo example, they're always learning about small errors, slips, and near misses to improve their system, so they don't wait for an actual failure. And that can be the same in things that went wrong, but the patient eventually was fine. But we still talk about that, for example. So here's another question. Teamwork and a culture of transparency and trust are important to protecting safety. How do you think teamwork promotes each of the principles of reliable design? Has anybody got any opinions on that?
I guess, James, it goes without saying, doesn't it, that if you've got a strong, cohesive team, then and that protects that time, then you've got the opportunity to use examples to reflect and learn from. But if the only cog in the system is kind of not working as well, then that process isn't going to be as slick or as streamlined.
Yeah, thanks. Yeah. And certainly there are some environments where we have a really sort of intentional way in which we foster good teamwork. So one might be, for example, a resus situation in ED, when patients come in into the resus area. If you've not been down to ED in Dunedin, you might see that there's a wall with lots of different stickers on it, and those stickers are stickers that people put on their bibs, which says what role they're performing, so that even although the team that gathers around the patient's bed is usually different every time, there's an easy way for each member of the team to know who the other person is and more specifically what their role is. So their name will be on this big sticker as well as their role. And then that way, communication is instantly improved in terms of getting people to do certain jobs that are required to be done quite quickly, like gaining IV access or getting the airway or putting in fluids and or who the team leader is, for example. So that's one aspect of where the teamwork is leads to a better patient outcome. What would happen if the zoo waited to redesign its system until an actual? Oh, we've talked about this already. Yeah. Well, what would happen is that they wouldn't improve so quickly, and yeah, in health systems, there is a lot of firefighting that goes on. We wait until a fire appears, and then we go put it out, and then we say, okay, what could we have done differently? And then usually what happens is an email is sent around saying we need to do this differently, and that's about it. But if you really want to make patient safety improvements stick, it needs more than just a firefighting approach. It needs an intentional, proactive approach to look at the root causes and then talk about, as a team, what are the ways in which we can mitigate these risks. Can you think of an example of a latent error from the zoo that staff took action to address? Or have you seen examples of latent error in healthcare? Anybody got any suggestions? So I guess one example of latent error in that zoo would be the bins that didn't have the plexiglass. So that was the actual environment. The bin itself created a specific area of risk, and then they addressed that by putting the plexiglass window in. Examples of latent error in healthcare. Let me think. Well, there is that really famous case where it was in the UK where a doctor injected vincristine intrathecally instead of intravenously and killed a patient. And part of the latent error there was the fact that the drugs look very similar because they're all clear, and the way you connect them to the tubes was the same, so you could easily connect them up to the wrong port and put the wrong drug in the wrong port. So one change that came about from that was that the connectors and the tubes and everything were all changed so that the drugs look very different. They came in different packaging, and you couldn't actually physically connect the wrong drug to the wrong port. So that's how that latent error was taken away. So you might notice that still there are drugs available on the ward, or particularly injectable drugs, which look very similar because the vials have the same shape, everything's colorless, and the labels are the same. So drug companies are trying to make them different by making the bottles look different, making the labels different colors, for example. And one way we can also make sure that they're different is by ordering from different manufacturers so that the packaging is pretty different. So that's another example of how you can improve latent errors in our system. So that comes to the end of it. Thanks very much indeed. If you've got any questions about patient safety, I'm very happy to answer them. Otherwise, I hope you have a good afternoon. Okay. Take care. Bye.